Okay, whenever you guys go and sit for the ARRT examination, they're going to have 33 questions for you that deal with patient care. Now, they basically just want to get a feel for how well you've learned the material. If you've studied and you've read the books a little bit, listened up in class, and hopefully gotten some of this stuff reinforced in clinic, then you're not going to have a problem. Anybody that doesn't know what they're talking about, you know, they're going to get weeded out by this examination. Now, there's several different sections of patient care. Ethical and legal, you know, we've talked about all that respondeat superior stuff. Interpersonal communications. You know, they're going to have some questions about how you deal with people, you know, on that level. Physical assistance. How do you get somebody on and off a wheelchair, to the table, back to the stretcher, without dumping them on the floor? Medical emergencies. What if all of a sudden somebody has a grand mal seizure right in the middle of a knee x-ray? Well, that could never happen. Yes, it has, to moi. You know, and it's scary, you know, when that kind of stuff happens. Infection control. Choo! Nice to meet you. Yeah, okay, we want to wash our hands, and we want to make sure that we don't poison our patients with germs while they're in our care. And hazmat. You know, when was the last time we had a serious chemical spill in the radiology department? Never. Well, yeah, knock on wood, never. Still, in every department there are MSDS, okay, and we're supposed to know where those are. We don't necessarily have to read them and memorize them, but we do have to be aware that there are hazmat procedures in place and what to do, and ARRT wants to make sure that we do. And pharmacology, you know, we're all out there with drugs in hand, so the ARRT wants to know that we are responsible and that we know the correct procedures behind administering medications. Don't forget about this thing, the patient's rights. The patient's rights. They have the right to confidentiality per HIPAA. You guys all familiar with HIPAA, I hope. The AHA, the American Hospital Association, lists out the patient's rights, and here they are. Right to privacy. We're not supposed to be blabbing about our patients, you know, outside of the healthcare environment. The extent of care. How far do we take things? Some patients have a living will, some people have a do not resuscitate order. So that's the kind of thing that needs to be brought to the physician's attention when they come in, like on a code blue, and you happen to be there and you have access to the patient's chart. Access to information. Okay, am I allowed to go in and check on Mr. Ron's condition? Because I know he's in the hospital. You know, can I pull up Epic and look up his information? He's my buddy. I know him, right? Exactly. It doesn't matter if it's your mom or your dad or, you know, somebody you met 12 years ago. You cannot just look up patient information without a legitimate reason. You can totally open their chart if they're in the department and you're working on them right this minute, because that's information that is important and you need to know it. Wonder if they have some allergies we should know about. Research participation. Not all hospitals. Some hospitals are teaching facilities. New Hanover Regional happens to be one of them. There are certain people at the hospital, patients, that are involved in research projects. And it can be stuff like knee replacement surgery. You know, maybe they're trying out a new appliance. Here's some legal issues for you. We're supposed to make sure that the patient we've got for an x-ray really is who we think they are. Has anybody ever brought a patient into the room for an x-ray and only then realized that you had the wrong guy? Yeah? Some people yes, some people no. Yes. Okay, before you pull the trigger on that x-ray machine, you want to make sure you check that patient's wristband. Because a lot of people, you go to them in the ED and you say, hey, are you Mr. Jones? Oh yeah, I'm Jones. No, they're not. They're Mr. McIntyre. You know, they're just confused. They don't know where they are. So it's up to us to make sure that this guy really is, you know, the correct person. Restraints and immobilization. Do you guys know the difference between those?
Yes. Restraints have to be ordered.
Correct. You cannot put somebody in cuffs without a doctor's order. Okay, that's called
False imprisonment.
false imprisonment. Very good, I like that. What about immobilization techniques?
Tape.
Yes, okay, immobilization techniques are simply to help the patient hold still for this particular image. They're not to strap them down to the table for an extended period of time. Okay, so we can't bind the guy down with a sheet to where he can't get up, but we can tape his fingers back, you know, for a finger x-ray to help keep him in position. Digital images. This is something that's relatively new over the last few years. The ARRT wants you to understand about the exposure indicators, how they work. Some places have a S number, you know, they're using the Fuji equipment. Some places are using the new quote-unquote standard AAPM exposure indicator. But either way, we want you to be able to tell, was this image overexposed, underexposed, or was it relatively accurately exposed? We're supposed to be using the correct histogram. No fair running an elbow under a hand. Okay, if you're shooting an elbow x-ray, make sure that you're using the elbow histogram. Window width and level. We all know how to manipulate the window width and level. This is important. Always reset that before you send it to PACS, and everybody's cool with why that is. True? Okay, masking and cropping. Good golly, I was at a clinic just the other day and I saw somebody doing this and I was like, okay, I thought that I had conquered this golem once and for all, you know, and that the masking and cropping of anatomy was dead, never to return. Darned if it hasn't reared its ugly head again. I understand the temptation. You know, everybody wants to be like the textbook radiographer that combs down exactly to the joint space. With masking and cropping, we can make it look that way. That's not ethical. Anything that got exposed to the x-rays needs to be brought to the doctor's attention. Yes, ma'am?
I think that's also an educational problem because seasoned techs recently discovered that the doctor has to read the entirety of the image, and if you cut it out, it's a problem. And they're like, I didn't know that. About cropping, it wasn't.
How would you know if somebody never told you? What gets to me, though, are the people that came through this program that have been here and they've heard everybody tell them how to do it, and then they go out and do whatever they want to do. And you can do that. You know, I mean, it's your responsibility. I'm just saying, just because you can do something doesn't mean you should.
Well, like even I resize the boxes, and I mean it makes the picture prettier because it stiffens it down, but the radiologist can still see all the anatomy. It just like if he can open it, they can open it back up so that they can resize it to like full region.
That's true.
So I mean you can make it pretty without actually cropping. So I mean I don't really think
I understand the why. I understand the temptation. You know, I mean, I'm tempted to do a lot of stuff. I'm tempted to drink whiskey and smoke, you know, but I don't necessarily do that because, you know, there's reasons not to. A little word from the ARRT. The radiologic technologist respects confidences entrusted in the course of professional practice, respects the patient's right to privacy, and reveals confidential information only as required by law or to protect the welfare of the individual or the community. This is relatively new stuff. So keep this in mind. You know, as an ARRT member, we're ethically bound to protect these patients to the best of our ability. Now, suppose a radiographer does disclose confidential patient information to unauthorized individuals, and so you might be found guilty of, and ooh, my animation messed up. It's not supposed to give away the answer until I push the button. But that's what it is, invasion of privacy.
I have a quick question. So
Fire away.
I'm sure you've heard about the nurse who wouldn't give the cop the blood work. Or
Yeah,
something or
that
nothing.
nurse was totally in the right.
Right.
And
So he would have
the
to
policeman
have-
was on a total power trip.
Okay. He would have to have like a
Nothing
warrant or
there.
something against the man.
Everything
Say-
that policeman did was illegal.
Okay.
He was breaking the law just as much as if he was smashing out the windows of a jewelry store.
I didn't hear about that. Wow.
You can see the video?
Some man
Wow.
I mean, it's hard to imagine an officer of the law with that little knowledge of the law carrying a gun. I mean, that scares me worse than an army of criminals. It really isn't. You know, there's reasons for that I'll not discuss here. Okay, a little communication. How would you guys like to communicate with people? Communication important for us?
Yes.
Yeah, absolutely. Okay, we have to communicate with one another and with the people that we're trying to take x-rays of. Now, this is sometimes challenging for various and sundry reasons. We've got to be able to speak clearly and communicate what we need. We also have to write it down. At the hospital, if something doesn't get written down, then it didn't happen. It never happened. It's just he said, she said. What about nonverbals? Okay, people that, they may not necessarily be saying something, but you can definitely pick up their mood. This is a terrible challenge for me because I'm an empath. If one person walks through that door in a crap mood, then it messes me up. I can't not feel it, you know? And, you know, sometimes kind of hard to shake off. But in a patient care environment, very valuable because a lot of these patients are nonverbal. So you have to be able to pick up on their, you know, wincing or, you know, any kind of, it's hard to teach that, isn't it? It's the kind of thing you feel it more than you know it. Language barriers. Se habla español. Have you guys ever had patients that spoke no English? I mean, seriously, they didn't know how to say hello. Yeah, well, how do you work with somebody like that? You got to tell them to hold their breath.
Non-verbals.
Si. Profunda.
That's her little iPad thing.
Okay, great, yes. There are interpreters at the hospital available. We're supposed to be using those guys because, okay, now I might be able to say, respira profundo y no respira, y no mueve. I can say a few things like that. Can I read a consent form to somebody from Russia? No way. You know, I would just never be able to do it. I've got to have an interpreter. Cultural issues. Good golly. Okay, there are so many machismo cultures that they're alien to us Westerners. We don't understand how in the world people can be stuck still in the year of our Lord 600. But they are, and they have these cultural taboos. You know, maybe men, I might not be allowed to touch a woman as far as her man is concerned. Then again, a female nurse may not be able to touch certain male patients. They just come completely unglued. Very difficult to deal with, and you know, but we have to. You know, here we are in North Carolina, and we're like a magnet to people from all over the planet. You know, they want to be with us, and so here they come, ready or not. Impaired patients. Some of your patients are semi-conscious, unconscious, delirious, just plain drunk, delusional. We don't know if they can hear us or not sometimes. They're out. We talk to them anyway. Okay, that is, and you're probably going to see questions like that on the registry. They'll say, you know, here's the situation. You got an unconscious patient, what do you do? Well, you talk to them, just like as if they were able to have a face-to-face conversation. Age. We got little kids, we got middle-aged people, we got old geriatric people. Different ways of communicating with each of those groups. Who here's really good at dealing with babies? Chances are, if you have babies of your own, or if you've got little brothers and sisters that you took care of when they were just babies, that is a huge help because, you know, you can just take care of another baby, you know, just kind of take it in stride. Now, whenever I first started having kids of my own, I was clueless wonder. I've never changed a diaper before. I mean, come on, I was a hotshot jet-setting computer programmer from Washington, D.C. You know, I wasn't changing diapers. I was changing planes. You know, and so having a family, it was a big learning experience, but I got really good at it. And emotional. Sometimes patients are, and it's tough to deal with, they're sick, they're dying. We know they're dying, but they don't know that. Or they know it on some level, but they have not yet admitted it to themselves. That's this business about, have they come to accept their condition yet? We have to work around that because it's easy to, you know, kind of open your mouth and stick your foot in it around patients that are at end of life, you know, so just something to be on the lookout for. Now, gerontologic patients. A radiographer should recognize that gerontologic, what does that mean anyway? Old, exactly. They have undergone physical changes that include the loss of what?
All of those.
1 and 2.
Oh, very astute. I can tell that you're going to do well. Yes, muscle mass, definitely. Bone calcium, aka osteoporosis. Yes, mental alertness is not a physical issue. It's a mental one. So you're exactly right. Mental state is not a physical change. Watch out for this kind of wording, because if you're just like flying through a test and you look at this, you'd be tempted to say 1, 2, and 3, because those all go with being old. More on communication. Hopefully you all are sharp on medical terminology, and you can explain to people in terms they can understand what's going on. And this is important here. Keep in mind, yours may be the first explanation that they've heard. So you need to be able to tell them, okay, here's the procedure we're going to be doing today. You're going to have a lumbar puncture. And when the doctor comes in, we're going to get you to lay face down on the table, and they're going to be inserting a needle into your back. It's probably going to be a little bit painful, but not bad. We're going to need informed consent. We've got to make sure that we get that. Pre and post exam instructions. Go ahead and load them up with this information. Tell them, okay, if they've been having a barium swallow, what are they going to be doing for the next few days? Drinking a ton of water, more so than they normally would. Because we don't want that barium to set up in their guts. That can give them like bad constipation. And other modalities. Wonder if this patient's getting ready to go to MRI next. And you don't necessarily have to be an MRI tech, okay? But to be able to kind of tell them what to expect once they get there, so that they're not just like totally shocked every time they walk through a door. Because sometimes these patients show up at the hospital and they're clueless wonder. They don't know what in the hay is going on. Yes, ma'am?
What's a good response when a patient asks, why am I having an x-ray when I'm going for an MRI after this?
Because the doctor thinks that, or they suspect that you might have some metal in your body. They want to just double check and make sure that there's not any. And if there is any metal, it'll show up on this x-ray. And that might tell them that you don't need an MRI.
What if they say, we're going for a CT after this?
We're going for a CT after
Then
this.
why am I getting an x-ray when I'm going for a CT?
Because a CT scan shows really, really good contrast. But the image detail is poor. So a lot of times the doctor needs like a high-resolution X-ray image, which we can provide, to go along with the low-resolution CT scan. There's just different information on those two, and the doc needs to be able to see them side by side.
And I don't know if Mariah's question is she was necessarily asking about metal, because I've had a patient before, like, we're doing a knee x-ray,
Yeah.
then you're gonna have an MRI.
Yeah, it was like
and
a
then
chest or
so-
something, so it was weird.
Same
I didn't
thing.
understand.
You know what I mean?
Okay, y'all know that cortical bone is invisible on an MRI, right?
Right, that's what, would you go into
Yes.
explaining that?
Say the doctor probably, and we don't know for sure, because
Doesn't
I ain't
know
no mind
exactly what's
reader.
wrong, so.
I mean, I kind of know what the doctor might be, I know what I'd be looking for.
Right,
Okay, I want to have an x-ray that I can correspond to the MRI slices, so that I've got the good spatial resolution on the one hand and the good contrast resolution on the other. that gives me the best of both worlds. It's almost like fusion imaging. Does that make sense?
Insurance. Don't think you have to have an x-ray before your insurance?
That's
will
a
pay for it, right?
possibility too. There has to be an imaging chain, because if you just like cut straight to the MRI, then that's liable to raise, I mean, the insurance company's probably gonna pay eventually, but they're gonna raise objections first. So if the steps have been followed correctly, then there shouldn't be any issue with reimbursements. Everybody knows not to dump the patient on the floor, I hope. Don't forget your body mechanics, okay? You're gonna see questions like, should you bend from the waist to pick up a heavy weight? Probably not, unless you're just looking to collect workers' comp. You should definitely bend from the knees, and always, when you're moving patients, this was one thing that I had to learn the hard way. When you're moving patients from the stretcher to the table or anywhere, make sure you've got your knees flexed during the motion.
And a wide base of support really helps too.
Wide base of support helps, yes. Feet shoulder width apart and all that good stuff. Whenever we've got a wheelchair and we're rolling our wheelchair up to the table, that should approach the table at an angle of about 45 degrees, yes. Medical equipment. Important in the department for sure, because sometimes we have patients that come in with IVs, so we have to transfer from the bed to an IV pole temporarily. We want to make sure we don't haul on those lines. A CV line can be pulled out. One of my co-workers at the hospital did it one time. It was a bloody mess, so you don't want to go there. We've got pumps. Now luckily, in the year of our Lord 2018, a lot of these pumps have gotten really, really small. Okay, they're not the big bruisers that they used to be. But still, we have to take care and make sure that they're plugged in, because they can only last for so long on battery power. This, if you don't know how these lines work and how these pumps work, ask a nurse. They will show you the basics. Now, they're probably not going to show you how to program a pump, but they can teach you stuff like how to, maybe reset the alarm and odds and ends like that that'll be important for you. Oxygen lines. Patient comes in with oxygen, we typically take the line and move it from the canister over to the wall, and we move it back. Just make sure that the patient, if they're on oxygen, they stay on it at that correct level, because some patients, if you give them too much or too little oxygen, then they might become acidotic or something, and we definitely don't want that. A lot of these patients have got NG tubes in. Hopefully the tube is securely taped. Still, be careful, don't haul on it. We don't want to pull it out. G-tubes, PEG tubes. Patients have got these things in their stomach. Again, it should be taped securely. Don't haul it out of there. Sometimes we're called upon to verify placement of tubes. Like they put an NG tube down somebody, they want us to come in and do an abdominal x-ray, check and see if that tube is in place. You guys know how to do that. You shoot an abdomen x-ray, but cheat a little bit higher. Should be good. But this is part of your patient care. Catheters, good golly. Okay, I don't know how many times I've done this, and it always makes me feel so bad. The patient's got a catheter bag on. I don't see it because it's up under the blanket. We go to transfer from the stretcher over to the table, and we leave the bag over there, and we bring the business into the catheter over here, and that causes the patient severe discomfort. So always check under the blankets, because you never know what this patient is hooked up to. My friend who's a nurse sent me this picture one day. It was just an impressive number of IVs. How would you like to go out on a portable and have to deal with this? Yeah, oh, the other side's got even worse stuff. Good try.
Don't pull it.
Yes, ma'am, that is a dialysis machine right now. Yeah, so this patient's hurting for certain. And the dialysis is running, because you see that?
Yeah.
When a patient with one strong side and one weak side is being assisted onto the table, what should we do?
B.
Good job. Okay, what in the world is going on with my animations? Yes, strong side closest to the table. And this also applies to doing wheelchair transfers. Okay, if they're hemiplegic, put their strong side close to the table. And that way they can kind of help you get them up onto the table. Monitoring vital signs. Registry will ask you things like what's the normal temperature in degrees Fahrenheit and degrees Celsius. It's about 37 degrees Celsius, 98 degrees Fahrenheit, roughly. Now, some people run hot, some people run cold, and that's normal for them. Like my normal operating temperature is slightly low. I'm not sure why. You know, it's just the way I am. Pay attention to your patient, okay? If we're performing an exam and this patient, you know, every minute that goes by, they're looking progressively more sick, well, that's something we should be taking note of. What's going on here? Are they desatting or what is their problem? You know, and be aware. If you have any doubt whatsoever, call your supervisor. You know, let them know. And that way, if things go south, at least you had given somebody some heads up so they can't come by and say, why didn't you tell anybody? Fall prevention. If somebody's got one of those wristbands on that says fall risk, believe it. It's probably true. Okay, watch them because they're going to think, you know, they're thinking that they're, who was that guy, Bruce Jenner, that was running all those races and stuff. You know, that's how they picture themselves, you know, like being this big athlete. That is not the case. You know, some of these people are really delicate, and if you don't watch them, they'll take a tumble. Excuse me, sorry. And documentation. If anything goes wrong during an examination, it's up to us to make sure. Now, we don't necessarily have to fill out the documentation as students, but we need to point out what went wrong so that the technologists can fill out the incident report correctly. And if you drop somebody on the floor, don't just run away. You know, tell somebody, you know, at least help them up. Emergencies. Allergic reactions. What do we do when somebody has an allergic reaction?
You stop whatever you're giving them.
Definitely that.
It's also what.
Yes. You know, call for supervisor. Help. Cardiac arrest. If somebody starts to have a heart attack, yes, and most of the x-ray rooms have got a blue button, so we can actually hit the code blue. Although, as a student, I wouldn't do that. Let a technologist, somebody that works at the facility, do that. Unless somebody, you know, if you're putting somebody up to the board for a chest x-ray, and all of a sudden, you know, their eyes go wide, and they grab their chest, you know, okay, then it's probably permissible to hit the blue switch at that point. Because you can see that this man is in a lot of trouble. Respiratory arrest. Some people don't really think too much about respiratory arrest, but it's a major problem. If your patient stops breathing, then they're going to not be supplying themselves with oxygen. That's just as dangerous as a heart attack. Physical injury. Hopefully our patients, you know, of course they're injured or else they wouldn't be in here for x-rays, but we're going to try not to injure them anymore. But if somebody does, you know, get cut or take a fall and hit their head on the corner of the table, that's another issue that we might have to deal with. And again, seizures. These are all reasons to call for help. You're going to see people come in with blood sugar problems, low blood sugar, high blood sugar. You know, diabetes is a big problem in the United States of America, something that we have to be aware of. And infection control. Be familiar with these terms. A pathogen, you guys know what a pathogen is? It's like a germ or a virus. It's something that can infect you. It's out there. It's all around us. However, without a reservoir is a place to kind of hide out and grow. A portal of exit. What's a portal of exit? A cough, a sneeze, you know, your mouth, your nose, those are very common. Some diseases spread by fecal matter, okay, so there's another portal of exit that's rather unpleasant. Modes of transmission, indirect, okay, there could be germs in the air that you could catch. There could be germs on a table that you come in contact with, versus direct. Direct infection is, you know, I've got a cut, now you've got a disease too. You're welcome. Portal of entry. Portal of entry. Your eyes, your nose, your mouth, possibly ears, skin in some cases. Especially, now normally your skin forms a bacteria-proof barrier. It's really good at keeping out bacteria. However, if you've got a cut on your hand, then watch out. Because now you've got an additional portal of entry, and especially in a patient care environment, you have to protect that. You don't want to give MRSA, you know, any kind of a staph infection, VRE, all that kind of stuff can enter you if you're not healthy and taking care of yourself. A susceptible host. Now, we're all susceptible hosts to some extent. Okay, when the flu comes around, nobody is flu-proof. We've figured that out this season. But this is really more from our patient standpoint. We're supposed to be protecting these guys. A lot of our patients, they might have had like a liver transplant or something like that. They are on immunosuppressive therapy for the rest of their life, which means that they are extra susceptible to diseases of all kinds. So we have to be careful, and even if patients aren't on some kind of a crazy drug like that, these guys are sick, okay? And when you're sick, that means that your body is already in a depressed state, you know, as far as being able to fight diseases off. You're susceptible to getting more disease, which is why those nosocomial infections, you know, we're trying really hard to prevent our patients from getting even sicker. I don't know why. Well, okay, I guess I do. The ARRT likes to ask about these things. Aseptic versus sterile technique. What's the difference between medical asepsis and sterility? Well, it's,
Yeah,
yes?
like, most versus all.
Yes. To put it in a nutshell, medical asepsis, this is where we are wiping down the room with Virex. We're trying to clean our cassettes. We're trying to get rid of as much germs as we possibly can. We are on the hunt, and we're spraying everything down that we touched or that the patients touched. We're trying to keep our rooms as clean as we can get them. Surgical asepsis is something else. This is sterile technique. You guys all know how to open sterile packages, sterile gloves. If anything gets contaminated, what happens? It all goes in the trash. Okay, we can't have any contamination. This is an attempt to keep the place microorganism free. And the OR, theoretically, you know, you go in the OR and you've got sterile versus non-sterile areas. Okay, in the areas that are sterile, we take special care not to run over with our C-arm, you know, because that would just be frowned upon. The process of eliminating as many organisms as possible by the use of water and disinfectants. C, medical asepsis. Okay, so you guys have got, I'm kind of driving this home because whenever I was a student, I was totally confused. I mean, my head was spinning. I couldn't figure out the difference between sterile and aseptic. I don't know why. You know, it doesn't seem like it's that hard. CDC says, use standard precautions. Precaution number 1, wash your hands. Before and after every patient. Supposed to. Have you guys ever heard that old joke about technologists are the only people in the world that wash their hands before they go to the bathroom?
Yes.
I think there's probably other disciplines that do this. I do that. I'm like, man, okay. Whatever's on these hands is going to get cleaned off first. Okay, wear your gloves and gowns if needed, and masks. Okay, protect yourself every chance you get. When you're starting IVs, I know, I come from the school of bare knuckle radiography. You know, I start IVs barehanded. Well, okay, I used to. We're not supposed to be doing that. Have y'all ever seen a technologist like put on gloves and then tear the finger off?
Point's the point,
Exactly.
but they swab their finger with alcohol first.
Well, I can mop down my whole hand with Purell or
I know.
whatever. Yeah, we're not supposed to be doing that. That's not considered as, you know, CDC best practice. Contaminated items, okay, this is the kind of thing you also see questions about. Anything that's got blood on it goes where? Into the dumpster? No, into a bio bag, a biohazardous marked bag. What about needles? Can we just throw needles into the garbage can?
Shark fin.
Sure we can, but we shouldn't. Those are supposed to go into the sharps bin.
So sheet has blood on it.
Sheet has blood on it. That's supposed to go into a bio bag and then go back to central stores.
What about if it's like, people?
Fecal matter, same thing.
Pee or-
It needs to go into a biohazard bag and then go back, because, okay, just because a sheet has got, okay, if we threw every sheet away that got crapped on, then we'd soon be out of sheets, okay? So those things go to the laundry, and the laundry, you know, they have specific methodologies for dealing with that kind of stuff. If they judge something is too far gone, then they'll incinerate it. All surfaces must be cleaned immediately. If in doubt, clean it with Virex. Common vehicle transmission involves what? Okay, C, food, water, medications, equipment. I like it. Very good. Another word of precaution for you. Okay, contact precautions. Some diseases can be transmitted just via touch. Absolutely possible. Droplet precautions. Okay, this is where if somebody coughs and they cough out a wad of something, you know, or just drops of fluid, droplet transmissions, yes, okay, we don't want any of that. Airborne, okay, airborne transmission. Some diseases, tuberculosis, for example, can transmit by way of just air currents. Neutropenic, have you guys heard of this?
No.
Some of the patients at the hospital are in what's called reverse isolation. They're in a high pressure room that has seals around the door, so that when you open the door, the air blows out, but it's supposed to keep any air from the outside from coming in. These patients are very immunocompromised. So we have to take special precautions to make sure that they don't get you know, subject to any further infection. When we're going out to do portable x-rays on these patients, which we do from time to time, we have to make sure that our cassettes and our machine and we are as clean as we can possibly get them before we roll into this patient's room. Because we're not so worried about catching a disease from them, we're worried about them catching a disease off of our plate. You know, that's a real thing. Nosocomial infections. You guys know what's the most popular nosocomial infection? UTIs, very popular. Pneumonia, the most popular, yes. But yeah, you know, if you stay in a hospital long enough, then especially if you've got a catheter in place, your chances of getting a UTI are pretty high. You could also wind up getting MRSA, but pneumonia is the number one. When people get to the hospital, they almost immediately start treating, you know, proactively or prophylactically, thank you very much, against pneumonia. And the other thing they've started doing, I don't know if y'all are aware of this or not, when patients come in and they're going to be in the hospital for more than a couple days, they will go ahead and start dosing them with something like heparin or warfarin, something like that, blood thinners, you know, to keep them from developing a DVT. All right, well, we'll have to see the rest of this presentation later because I see by the clock on the wall we've run out of time. But don't worry, we're going to get back to this later.
That is hard.